Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a neurosurgeon called Dr. Ian Marsh, who specialises in the treatment of concussion in sport. You now have 90 seconds to read questions 31 to 36.
My guest today is Dr. Ian Marsh, a specialist in the treatment of concussion in sport and a co-author on a new set of guidelines. So, Dr. Marsh, what's the aim of these new guidelines?
Well, the aim was really to provide a resource, not for the top-level professional sports people, but for parents, teachers and coaches of young people playing sport. The guidelines basically offer some expert information from a GP, an emergency physician, and myself as a neurosurgeon about what the condition is, also how to identify the symptoms and how to manage it. If any of your listeners have ever had a concussion doing sports, you'll know how frightening it can be. It's confusing and painful and difficult sometimes for teachers, parents or whoever to work out if someone with concussion is okay. I mean, we hope to remedy that.
And how do we know when someone is suffering from concussion?
Well, obviously, if the person's actually knocked out, it's clear. But not all patients actually lose consciousness. Often, following a hard knock to the head, they become disorientated or experience headaches, nausea or vomiting. These are signs of concussion, and they may clear initially, but then return when the individual actually undertakes further physical activity, when they start to train, say. So it can actually take quite a while for things to really clear up. The essence of it is that people shouldn't start playing again until those warning signs have completely subsided.
Yes, and you say that waiting anything less than 14 days after all the symptoms have cleared would be too early to return.
Yeah, that's right. If they go back too early, they risk a second concussion. And, as we know from professional athletes, they may have to give up their sport if they have too many concussions. So it's better, particularly in a young person with a developing brain, to allow all of the symptoms to settle and only then return to play. Well, usually return to train first, then return to play after that. It used to be thought that receiving another concussion could lead to severe brain swelling, and that could be fatal, or at least involve a visit to the emergency room. I think the evidence is fairly slim for that. What we do know, though, is that the compounding effect of having one concussion followed by another seems to be more severe than just the one. So it's always better to let the brain recover fully before playing again.
Right, so who's at the highest risk of sports concussion?
Well, actually, a concussion can happen whenever anyone receives a blow to the head. Usually it's a sort of twisting blow, not a straight-on blow. But obviously, people playing sports like rugby, where there's bodily contact, stand more chance of being at the receiving end of such a blow. But having said that, it's just as likely to affect kids kicking a ball around a park as it is to affect top professional players in big matches.
Do you think that youth sports need specialist concussion doctors on hand, like the professionals do?
There's always a risk, and we know that it happens from time to time. But I mean, most games, even the most dangerous ones, are without incident at all. I think people who are involved in running youth sports, whether they be referees, coaches or parents, can be made aware of how to manage concussion, the signs that they need to look out for, and maybe the warnings of something more serious so that they can take the appropriate actions. But I think always having a doctor on the sidelines where young people are playing is just an overreaction.
Right. In the USA, college football is big business. They're trialling helmet sensors and impact sensors. Do you think that's something we need everywhere?
Well, I don't think it'll come to that. I think there are two scenarios here. The first is one where a concussion's a one-off event following a significant blow to the head.
Right.
The second's quite different and involves chronic traumatic encephalopathy. This comes about particularly in American football, where players use their helmets and heads almost like weapons. That type of repeated impact seems to add up over the player's career. That's something we've heard being discussed, mostly in the USA. Naturally, there's interest generally in protecting players, particularly in the professional levels of sport, but I see that as a different matter to the management of concussion itself.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a presentation by a consultant cardiologist called Dr. Pamela Skelton, who's talking about a research trial called SPRINT, which investigated the effects of setting lower blood pressure targets. You now have 90 seconds to read questions 37 to 42.
Hello, I'm Dr. Pamela Skelton, consultant cardiologist at this hospital, and I'm talking about the recent SPRINT study into the effects of setting lower blood pressure targets, which in turn affects the advice and medication which patients are given. I'm going to describe the patients who were selected, how the trial was conducted, and the implications of its results for us all as health professionals. First, the trial itself. It involved over 9,000 hypertensive participants, aged 50 plus, most of whom were on blood pressure medication. They were randomly assigned to one of two groups, one with a goal of less than 120 millimeters systolic BP, the other with a goal of less than 140 millimeters, the traditional standard. The intention was to follow these patients for 5 years, factoring in the usual dropout rate. As it turned out, however, the trial was stopped after just 3 years, thanks to an all-cause mortality reduction of nearly 30% for the 120 group, which was definitive and shocking, but wonderful. As I mentioned, the participants were over 50s, and it goes without saying that as people age, they develop more diseases and health problems as a matter of course. But there was a specific group of over 75s who did just as well as younger patients. Before the trial, some medics referred to the natural stiffening of the arteries with ageing, suggesting that 120 was too low a target for the over 75s, risking an increase of dizzy spells, which would affect general well-being. But this concern turned out to be unfounded. Others thought there would be a failure to take the number of tablets needed to reach a BP of 120, especially among older participants. Again, this wasn't an issue. The average needed was just 3 per day. The over 75s, already on various drugs, didn't object to extra medication. Participants from this age group who didn't finish the trial were taken out because some conditions, which were already present, worsened. For example, in some cases, obesity levels rose too high. To manage their blood pressure, participants were given standard drugs, nothing experimental, just drugs that are readily available and low cost. Another key factor was that blood pressure was measured in a very specific way. Rather than give patients an arm cuff for at-home 24-hour ambulatory monitoring, an automated machine was used at the hospital. This took 3 separate readings and averaged them. Also, readings were taken while staff were out of the room to avoid what's called white coat syndrome in patients. Now, some of you may be familiar with the ACCORD study into blood pressure levels several years ago, which in some respects was similar to SPRINT. There are some differences, though. For example, ACCORD was about half the size of SPRINT, and unlike SPRINT, the ACCORD study allowed diabetic patients to take part. Despite this, in general, the ACCORD participants were rather lower risk than those in the SPRINT trial, probably because of the slightly lower average age. The ACCORD trial didn't show a statistically significant benefit for overall cardiovascular outcomes, but there was a clear 40% reduction in strokes, even though that was a secondary outcome. So, to summarise, the SPRINT trial seems to support 120 as a recommended blood pressure target. This is doubtless a landmark study, and, importantly, one which was sponsored by government rather than by the interests of pharmaceutical corporations. I recommend a note of caution, though, as SPRINT does contradict previous findings. The Cochrane review, in 2011 for example, said that lowering to under 140 didn't produce a change in the risk of death overall. However, we must bear in mind that Cochrane was looking retrospectively at trials which weren't actually focused on the same particular issue. So it's worth doing a full and systematic evaluation to see where the SPRINT trial fits in with what we already know. It's interesting that a few GPs have already been working with older patients to hit lower blood pressure goals, and the new data will doubtless encourage greater take-up of this more interventionist line of attack. But the sprint results don't mean that everyone with hypertension should be dropping to under 120. Plus, to achieve those lower levels, it's unlikely that lifestyle changes alone would be enough. It could well require several antihypertensive drugs as well. There remain some unanswered questions, of course. For example, whether other groups, like those with a lower heart attack risk, need to keep their blood pressure that low. So, while Sprint can help guide doctors' decisions about some patients, it doesn't mean that a new universal standard for blood pressure is in order. Instead, it's a good reason for everyone to discuss with their doctor their own ideal and particular target.
That is the end of Part C. You now have 2 minutes to check your answers.